And the floor is yours.
Thank you very much. Good afternoon, everyone. On behalf of HEAL, the Health and Environment Alliance, I would like to welcome you all to this webinar on reducing costs from air pollution, strengthening prevention, which is co-organized by HEAL and the EU Health Policy Platform. My name is Anne Stauffer. I'm Deputy Director at HEAL. We're an alliance of non-governmental organizations bringing together over 70 member organizations working for better health through a healthier environment. And I'm pleased to see all of you gathered here today, including representatives and participants from medical universities, from national public health institutes, and from civil society organizations. HEAL is teaming up with the EU Health Policy Platform for this webinar to raise awareness on the health cost of air pollution and build capacity on the opportunity to strengthen disease prevention through cleaner air. There's a large body of evidence demonstrating that air pollution is a major health risk and actually a key risk factor for non-communicable disease. In the European Union, as in other parts of the world, air pollution is the top environmental threat to health. And the list of health impacts of poor air quality is long, and it unfortunately keeps growing. Air pollution has been established as a cause for respiratory disease, for cardiovascular disease, for cancer, for neurodegenerative disease, thus adding to a growing disease burden and leading to thousands of premature deaths annually and significant health cost. In the past years, new science has also highlighted how air pollution impacts children's healthy development, how it links with socioeconomic health inequalities, and also with mental health. No one can choose the air that a person breathes. With the right policy measures, the health impacts of air pollution of poor air quality are largely preventable. And we will hear more today in the course of the webinar on the cost burden of air pollution and the EU policy measures for prevention. We're organizing this webinar on a very special day. As 4 years ago today, on the 22nd September 2021, the World Health Organization published the updated air quality guidelines, the first update since 2005. For these guidelines, WHO and leading researchers in the field systematically reviewed hundreds of peer-reviewed studies and recommended lower, that means stricter, maximum concentration levels for the main air pollutants, including particulate matter and nitrogen dioxide, pollutants which cause the largest health burden. The member states of the European Union now have the opportunity to make Europe the first continent to fully align with these WHO recommendations through an ambitious implementation of the recently revised EU Ambient Air Quality Directive, going beyond what is legally required. HEAL and a record number of health organizations have been engaged for clean air. As studies published also after the guidelines came out confirm that there is no safe level of air pollution and confirm the urgency to act. And our webinar today is also timely because air quality will certainly be a topic at this week's 4th high-level meeting of the UN on non-communicable disease, which is taking place on the 25th of September. So in today's webinar, we want to focus on the health cost aspect. And I'm pleased that we have a range of distinguished speakers here to help us shed light on these questions and share some good practice on assessing cost and health cost burden from Belgium, from France, and from Poland. And I'm also pleased that we will also have a European Commission DG Environment representative with us. So before we start, a reminder on housekeeping. For those who joined late, we do want to make this an interactive webinar. So please, for any questions, do use the Q&A function, which is on the bottom right with 3 dots. Bottom right, 3 dots. And use the chat also to introduce yourself. This webinar is being recorded and will be available on the EU HPPP platform and on HEAL's YouTube channel. And with that, let's get started to hear our excellent presentations. And I would like to welcome the first speaker, which is Mr. Ludo van den Toren from the Independent Health Insurance Funds, who will talk to us about the costs of air pollution in Belgium. Ludo, the floor is yours.
Thank you, Anne, for this wonderful presentation. So
Yes, I'm Ludo van den Toorn from an expert in scientific and economic matters at the Belgian Independent Health Insurance Funds. And for the next 10 minutes, I will talk about the impact of air pollution on health, public finances, and social inequalities. I'll begin with a brief introduction to our own health insurance funds, and then I will give some key findings about 3 of our studies. And in conclusion, I will also end with some key messages and takeaways for you. So Belgium is quite known for its accessible high-quality healthcare system, which is built on the foundation of compulsory social health insurance. And it's an integral part of our social security system, with nearly 99% of residents being covered, which makes it one of the most inclusive systems in Europe. So as the Belgian Independent Health Insurance Funds, we comprise 3 big health insurance funds, Partenamut, which is the French-speaking one, Vrije Krankenkasse, which is the German-speaking one, and then Helan, which is the Dutch-speaking one. And we represent about 2.3 million people in Belgium, which makes it about 1 in 5 Belgians. And environmental issues have been, and the impact on health have been quite a key focus for us. And we're very proud to be able to present our results today. So our first study examined the impact of short-term exposure to ambient air pollution and the onset of work incapacity related to mental health conditions. So in Belgium, we see work incapacity as the moment that the health insurance funds begins to fully pay the person instead of the employer. And what we noticed was that during the year 2019, we selected only the people who lived at the same address during the full year. And we noticed that the median number of days in which people were on work incapacity was 120 days. And what we noticed was that pollution peaks actually contributed to an increase in the number of people recognized in work incapacity or being absent from work for a long period of time due to mental health disorders, like, for example, depression or burnout. For example, an increase of just 5 micrograms of nitrogen dioxide per cubic meter of air increased the risk of working capacity by 4.2%. And for black carbon, an increase of only 0.5 micrograms per cubic meter increases by 3.2%. So this suggests that there is a clear link between air pollution, well, higher air pollution, and increased mental health related incapacity. In our second study, we built further on this, and we looked at the association of air pollution and green space with all-cause general practitioner and emergency room visits. We also looked at the year 2019, but this time we only took the people aged between 10 and 64 who lived at the same address. And our results actually showed that the higher the air pollution, so in here PM 2.5 was, the more that people had an average of annual GP visits. As you can see, at the lowest ranges in Belgium, the average was 2.96 GP visits in 2019. And for the highest PM 2.5 levels, it was 3.30. So what we did was we wanted to see what happens if the air pollution is actually at the level suggested by the WHO, which is supposed to be below 5. And so we looked at 4.91 until 7.49. And what we saw that was among our members, we could nearly save 200,000 visits annually if air pollution was at good levels. Economically and extrapolated to the whole Belgian society, this would actually represent about 43 million in potentially avoidable costs of visits. of which 37 are actually borne by the health insurance funds, and 6 million euros are actually out-of-pocket payments by the patients themselves. In our most recent study, we looked at the positive impact of the introduction of low emission zones, most specifically in Antwerp and Brussels, on air quality, socioeconomic disparities, and on health. We looked at the period from 2016 until 2022, and our results were multifaceted. First of all, what we noticed was that the low emission zones are quite effective in reducing air pollution, with faster decreases found in low emission zones as compared to non-low emission zones. And these effects of the low emission zones are visible up to 5 kilometers outside of the low emission zone. Second, and this was more concerning, our study also confirmed that the less affluent members tend to live in more polluted areas, as you can see here by the people being represented with lower, less affluent people being represented by the dark color, and the more affluent they become, it becomes lighter. Also, what we found was that the socioeconomic inequalities actually, the low emission zones help to decrease them. So as you can see, for example, for NO2 and black carbon, we noticed that the low emission zones help to reduce at a faster rate for the less affluent members as compared to the more affluent members, even though the less affluent members still hold more, will still live in areas with worse air quality. However, for PM10 and PM2.5, the difference was not significant in the decrease. So some of the key messages we have for you are: air pollution is a risk for public health in Europe, with not only an impact on physical health, but also mental health and working capacity. And we're proud to say that the Belgian Constitutional Court also recognized this aspect as a reason to tell the Brussels government to not delay the low emission zones in Brussels. Also, reducing air pollution is protecting the financial sustainability of the social security system. And policy on air quality needs a social and socioeconomic dimension to tackle these health inequalities. All of our studies have been published and peer-reviewed, and once you will get the presentations, you will be able to click on the images to end on our publications. Should you have any additional questions after reading the articles, you can always contact me at the following email address. Thank you to the UHPPP and also to Hale for allowing us to present today. Thank you.
Thank you very much, Ludo, for kicking us off here with the evidence from Belgium. And thank you also for sticking to the time. And the invitation to everyone again to please ask your questions on this presentation in the Q&A, which is, you'll find it where you see the 3 dots at the bottom right of your screen. Q&A function. We are now moving on to our next speaker, which is Mr. Olivier Chanel from the University Aix-Marseille CNRS AMSE, and to hear about the estimating the morbidity from air pollution and its economic costs in France, a case study. Olivier, the floor is yours.
Thank you. Hi, everyone. I'm Olivier Chanel. I am CNRS research professor at AMSE, and I'm going to present today some results based on the EMAPEC project. This is an international project led by the WHO Europe. It involved about 20 international researchers for more than 3 years, and the final report is going to be published by the end of the year. I was a member of the economics team and also participated in the case study for France. There were 2 other case studies were for Italy and United Kingdom. And I'm going to focus today on the economic results of the French case study. I'm going to present briefly how the health impacts have been computed, and then to spend more time on the methodological aspects of economic assessment, present the main economic results for France, and then conclude. So the study period was 2016-2019. It involved the mainland France and Corsica at the municipality level. And I'm going to present today results based on 8 long-term diseases. That is the incidence of lung cancer, of chronic obstructive pulmonary disease, of asthma in children and in adults, of acute lower respiratory infection, of stroke, on ischemic health disease events, hypertension, and type 2 diabetes. I'm going to present results for 2 pollutants, PM2.5 and NO2, and finally for 3 scenarios. The first one, referred to as the total burden scenario, represents the impact of a situation without anthropogenic pollution. The second one is a compliance with the WHO air quality guidelines. And finally, the third one represents the respect of the 2030 European Directive. For the health impact assessment, there are several steps. The first one is to estimate the pollutant concentration. This has been done by INERIS, and you have 2 figures here that represent the situation in 2018 for NO2 and PM2.5 in France. Then there is a population exposure assessment step, which has been done by INERIS too. Then we have to collect the health data on incidence at the municipality level, and this has been done by Santé Publique France. And finally, we use the concentration response function for the 8 diseases based on the EMAPEC project. Overall, this allows to compute the annual number of cases by pollutant, by disease, and by scenario. And this has been done by Santé Publique France, and especially my colleagues, Magali Corso and Sylvia Medina. So the main health impact assessment results are as follows. For the total burden, between 12 and 20% of new cases of respiratory diseases in children are associated with this scenario, and between 7 to 13 of new cases of respiratory, cardiovascular, and metabolic diseases in adults. For the second scenario, the compliance with the WHO AQG would avoid about 75% of the morbidity attributable to PM2.5 anthropogenic pollution, and about 50% of the morbidity attributable to NO2 anthropogenic pollution. And finally, respecting the 2030 European Directive would avoid more or less about 13% of the morbidity attributable to PM2.5 and NO2 anthropogenic pollution. Then we move to the methodological aspect of the economic assessment. To have to associate an economic impact or cost to each of the cases. So we focus on 3 cost components. First, health costs that represent medical resources consumed and non-medical resources linked to the disease, and they will be based on prices and tariffs. Second, the production losses, PL, that represent lost resources, that is loss of production by the patient or the family, and presenteeism, and they will be based on salary. And finally, these 2 first components were tangible or marketable cost. And finally, we add an intangible component, IC, which represent the cost of disutility for patients and their families, grief, fear, pain, unhappiness, loss of well-being, loss of quality of life, and they will be based on approximated real markets. So now there are 2 main issues associated with long-term morbidity economic assessment. The first one is that we have to compute the lifetime economic values for each disease. And there are 2 cases, and we used 2 formulae. First, for lung cancer and stroke, because they significantly affect survival and the cost components vary with the time elapsed from onset. And for all the other diseases that do not significantly affect survival and whose cost components do not vary a lot with the time elapsed from onset, we use another formula. The second issue deals with the fact that we have to account for lag issues for cost-benefit analysis, and these for 2 reasons. First, because of the implementation time frame, the change in population exposure will not be immediate, but gradual due to political technical implementation timescales. And second, because we are dealing with long-term health impacts, we have to account for the cessation lag. That is, the long-term health effects result from the impact of a cumulative process on health status, and so their degeneration and improvement are not immediate once exposure has ceased. So overall, we found that HIA-based economic impacts should be decreased by between 11 and 15%, depending on the disease and on the implementation of reduction policies, when they are going to be used in cost-benefit analysis in order to account for these lag issues. So now we have to compute the lifetime economic values for each of the diseases. For the health costs and production loss, they are based on literature review and on French-specific data. And for the intangible components, they are based on the average disability adjusted life year per case and the monetary valuation of this disability. We use the amount of 45,000 euros per daily. So here in this table, I show the lifetime economic value for each of the 8 disease, 9 health indicators, because there are 2 for asthma. You have the average duration per case, the daily per case, the health cost, production losses, and the intangible component. And we can see that, as expected, they vary a lot depending on the disease. And so we apply this value to each of the scenarios, each of the cases associated to each of the scenario, and we have the following results. I show here the potential annual economic benefits of reducing annual mean for 3 reduction scenarios. They are expressed in million euros. On the left, you have the results for NO2, and on the right for PM2.5. And you can see that the largest impact are those associated with the reduction to anthropic threshold for the PM2.5, with around 12.9 billion euro per year. You can see the results for the other scenarios. We can also have a look to the composition of each of these amount by considering the shares of for health cost that represent for NO2 about 31% of the overall economic impacts, for production losses about 32%, and for the intangible component about 37%, and for PM2.5, these results are respectively 41% for the health cost, 15% for the production losses, and around 44% for the intangible component. We can also express these results in euro per year and per inhabitant. And here we can see that they spread between 7 euros and almost 200 euros for the case of reduction to anthropic threshold and PM2.5. Finally, this figure shows the potential annual economic benefits by disease of reducing annual mean levels to the WHO AQG. And so on the left, you have the results for the NO2, and the largest share is associated with asthma in children with about 1.2 billion euros per year. And for PM2.5, the 2 largest shares are for asthma and COPD, asthma in children and COPD, with around 3.2 billion euro per year. So to conclude, the main results are that reducing exposure to air pollution will reduce health and economic impacts, with priority given to chronic rather than acute exposure. We found that if the WHO AQG value for PM2.5 was respected in France, then the annual health and welfare benefits for the 8 long-term diseases studied would be around 9.6 billion euro per year. And this amount is composed by at 34% by asthma in children, 34% by COPD, 10% for stroke, and 10% for type 2 diabetes, and the remaining percentage are associated with the other diseases. And finally, the long-term morbidity represents about 10% of long-term mortality in economic terms. And here you have the future issues we plan to consider: adding new disease, conducting sensitivity analysis on cessation lag, and exploring the feasibility of multi-pollutant estimations. Thank you.
Thank you very much, Olivier, for your presentation, which shows very clearly the importance or the percentage, the role that air pollution plays in these chronic diseases highlighted, and also the significant cost reduction potential through clean air, not to speak of alleviating or lessening the suffering of those people living with disease. Again, if you have any questions on this please use the Q&A function. We're now moving on to Poland and to my colleague Olga Wozdowiak, who will present to us on the external health cost of air pollution in Poland. Olga, the floor is yours.
Thank you so much, Anna. So my name is Olga Wozdowiak. I'm an environmental health policy specialist in HIL, and I work in Poland. And to start this presentation, I will present a few key facts about air quality in Poland. So first of all, Poland ranks among the European Union's most air polluted countries, and that still remains despite the gradual progress that Poland has made through the years. What is more, according to WHO data, 36 out of the 50 most polluted cities in the EU are located in Poland. So what are the main sources of air pollution? The main sources in Poland are related to coal use, which can be, of course, differentiated between residential heating, industrial use, and energy generation. However, it is estimated that around 8% of particulate matter and also almost 90% of benzopyrene comes from burning coal in household stoves. This, of course, the high levels of air pollution, of course, significantly impacts the burden of disease and premature deaths. And the European Environment Agency estimates that in Poland, around 47,000 people die prematurely annually due to diseases related to air pollution. Why do we talk about costs when it comes to advocacy work, working with policymakers? First of all, the economic impacts of air pollution are a key aspect of the health debate that I hope I will be able to present later on. The health costs of air pollution and overall triple crisis are also avoidable. And what is more, lack of effective action and regulation cost us more than investments to reduce air pollution. There was also this interesting analysis published by Boston Consulting this year that argues that the economic implications of the triple crisis are not that widely discussed or properly understood by policymakers and are often underestimated. So, as we know, air pollution generates serious public health impacts and, of course, significant economic burdens in the form of so-called external costs. So I will try to work it out on an example. So in 2023, we had Maciek, the first Polish kid who was diagnosed with bronchial hyperactivity due to air pollution. He was growing up and living in one of the heavily polluted cities in Poland, and he has been presenting symptoms for years: cough, dyspnea, more frequent respiratory infections. Of course, that meant that he went through a detailed diagnostic process, and doctors confirmed, after ruling out all the other issues, that his symptoms are associated with exposure to air pollution and are also exacerbated by it. So what are the costs borne both by the health system, by the family, by Maciek himself? As I mentioned, the diagnostic process, regular doctor visits, cost of monthly treatment, they're of course partially paid by state and by Maciek's parents. Unfortunately, this exposure to air pollution can impact his whole life, as he has a susceptibility to develop chronic illnesses, and not only respiratory ones, but also cardiovascular. And due to the symptoms, he has, of course, more frequent infections. He loses days at school, his parents have to take care of him, so he loses days at work. And of course, Maciek is simply not feeling well, and it has impact on his overall well-being and functioning. So we can, of course, divide those costs, as Oliver previously mentioned in his study. For advocacy purposes, we divided this to direct costs, healthcare costs, including diagnostics and treatments, indirect costs that consist of, for example, loss of productivity, lost work days, premature deaths, and of course, the costs that are often the most difficult to measure, the intangible costs of patients' pain and suffering. And again, ambient air pollution is one of the most significant environmental issues affecting people's life in Poland, affecting their health, their well-being. It is, as you can see on the two maps of the European Environment Agency, linked to increased mortality from cardiovascular and respiratory diseases, and what is more, including to air quality life index data from 2023, average citizen in Poland loses around 9 to 10 months of life due to air pollution, but there are also some heavily polluted regions that it can take up even up to 14 months of their life because they're breathing dirty air. So how much does it cost in more of a monetary terms? So based on the study from 2024 by Olju and Barton, they estimated costs both of air pollution both for Europe and of course include Poland. And they based their study on the previous estimates of OECD, focusing mostly on PM 2.5, annual concentrations, and reduced labor productivity and absenteeism. As you can see, yearly in the years from 2014 to 2020, Poland paid 60 billion euros, which is around 30% of the national GDP due to air pollution. And from 2024 to 2030, the estimated yearly cost is around 80 billion per year, which is around 11% of the national GDP. And how does it compare to selected EU countries? Of course, like air pollution levels, the associated economic costs are not spread evenly across the EU countries. So when at the EU level, the cost over the period of 2014 to 2021 was estimated at 6% of GDP. As I said previously, in Poland, it was 13% of GDP. And when we look at how is the share of all the countries, and especially of Poland, in the overall GDP spending for air pollution in the EU, it's over 10%, which is the highest in the European Union. But I also want to highlight that comparing it to the gap that we currently have for actually tackling pollution in Poland, which is 1.6 billion per year, and that's only, or mostly rather, for air pollution. You can see that the 80 billion that we pay per year is like the investment gap is only like 2%. So I wanted also to highlight that a lot of studies, also including UN ECOSOC Commission for Europe from 2022, they highlight that business as usual is even up to 25 times more expensive than additional clean air policies, but actually according to the recent study by the World Bank, efforts to accelerate decarbonization in Poland could actually accelerate economic growth by at least 4% of GDP compared to current policies. And I just wanted to highlight by the end the work that HEAL in Poland does towards clean air. We work with a wonderful group of doctors and healthcare experts to advocate and to change policies in Poland to make sure that our air is better. Recently, we have published a policy brief for decision makers that focused on the health costs of air pollution and climate change. This year, we also, this month, we have also sent a letter to Prime Minister Tusk with a great media coverage with healthcare experts with specific recommendations towards achieving clean air in Poland. We work closely with experts, doctors, and we prepare educational materials. And that's it from my side. If you have any questions, please feel free to reach out. Thank you.
Thank you very much, Olga, for highlighting the significant cost of inaction on clean air in Poland, which underlines again why we need to see greater policy commitment, but also to making clear to everyone what air pollution means then in the daily life of those who suffer from diseases that are linked to air pollution or aggravated by air pollution. We are now moving on to our last speaker, which is Mr. Thomas Henrichs from DG Environment in the European Commission, who will present to us on air pollution and the environmental implementation review. Thomas, the floor is yours.
Thank you, and good afternoon. And, thank you for this kind invitation to speak at this webinar on this EU health policy platform. And I'd like to start off by thanking the previous presenters for having provided insights to the health impacts and the cost of air pollution already. We're very informative, and this makes my task too easy in the next 10 minutes to focus on the policy aspects. So what I would like to do is to briefly present the EU Clean Air Policy Framework, to highlight what we've already done to strengthen this policy framework further, and to highlight some of the implementation priorities, to finish them off with an emphasis on what we need to do next. Having said all this, I would like to start off with a slightly positive note, which is a simple observation that notwithstanding all the severe impacts we still see air pollution to have, and the previous speakers have rightly pointed to this, the data also shows that clean air policy works, meaning what we do makes sense and seems to deliver results. Over the past decades, we have been able to reduce air pollution significantly. Since 2005, we have reduced the emissions of air pollutants across the EU by between 80% for sulfur dioxide, 30% for particles, and well, just about 10% for ammonia. But at the same time, economic growth has continued, and we have seen the gross domestic product rise. All of this to show that combating air pollution does not come at the expense of our economies. Over the same period, and as this graph shows, premature deaths attributable to pollution by fine particulate matter, so PM2.5, which we consider to be the key indicator, have reduced by some 45%, and we are well on track to meet the zero pollution target of 55% reduction by 2030. But, and this is important, this still leaves 239,000 premature deaths estimated for the year 2023 alone, alongside a high number of related diseases and illnesses, as we've just heard. This makes air pollution still the most relevant, the biggest environmental health risk. And this, of course, we need to address, but at least, and this is what I was trying to convey, we have a good notion on how to do this. Namely, by continuing with the three-pillar approach that we have in EU clean air policy. First, we have an ambient air quality directive, which establishes air quality monitoring systems and sets air quality standards, meaning concentration levels for key air pollutants that should not be exceeded anywhere in the EU. This we have revised last year, and I'll come back to this. Second, member states have agreed to limit their respective national total emissions of 5 air pollutants, both via international commitments under the UNECE Air Convention and via the National Emission Reduction Commitments Directive, or the NEC Directive. And thirdly, we've established upper limits for key pollutant sources, such as in transport, in industry, and in the energy sector, for example, via the recently updated Industrial Emissions Directive, and also via the recently updated Euro standards for vehicles, or eco-design rules. I mentioned that last year we revised the Ambient Air Quality Directive, but what does this actually improve? The revision that we did covers 4 key areas, and I'll quickly summarize them without going into detail. First, we, in the environment and health domain, we set a zero pollution objective to be met by the year 2050 at the latest. And to set us on track to such a trajectory, we revised the air quality standards to be attained by the year 2030, downwards to levels that I will show in my next slide. In other words, for 12 pollutants, we align air quality standards in the EU more closely, but not fully with the WHO recommendations. Secondly, in the area of governance and enforcement, we now have a regular review mechanism to adapt the directive more swiftly to recent scientific findings. We make air quality plans more effective to stop and prevent exceedances of EU standards, ideally before they even happen, and we improve the enforceability thanks to new provisions on access to justice. As regards monitoring and evaluation, we have a good air quality monitoring system already in place in Europe. 4,000 monitoring stations speak to this. Still, we established a revised and further improved approach to air quality monitoring, and especially focus on an increased use of air quality models. And for the first time, we mandate monitoring of other pollutants like ultrafine particles, black carbon, or ammonia. And in the area of information and communication, the revised directive now strengthens the availability of up-to-date information on air quality, including via requirements for air quality indices to provide hourly reporting of available air quality data. Also, more information on health impacts shall be provided to the public. I'd like to come back to the values of the air quality standards I mentioned before and give you some details on this. In this admittedly rather complex graph, you see for each pollutant of the 10 that I've listed, 3 different bubbles. In the light blue on the top, you see the values put forward by the WHO air quality guidelines 4 years ago, as Anne has mentioned. In dark blue at the bottom, you see the standards that apply in the EU until the year 2030. And in the middle blue, you see the new standards that will apply as of 2030. There's room for postponing some of these standards by up to 10 years under specific circumstances, but even so, you can see that the co-legislators have decided to make significant steps towards aligning EU air quality standards more closely with the WHO recommendations. In detail, it can be seen that the limit values in the calendar year for the pollutants particulate matter and nitrogen dioxide, which we mentioned before, will be reduced from 25 and 40 micrograms respectively to now 10 and 20 micrograms per cubic meter respectively. Furthermore, we've introduced a so-called average exposure reduction commitment for these 2 pollutants for regions which apply as long as they exceed the WHO levels. So what do we expect as a result from this revision? Well, in sum, we expect the benefits of the revision to significantly outweigh the cost. First, we expect health benefits. We've calculated that the reduction in premature death and morbidity would be 50% faster than if we hadn't done this revision. Secondly, we expect social benefits, as stricter limit values tend to protect people at particular risk. Thirdly, we expect environmental benefits with a decreasing in eutrophication and acidification, and also a reduction in loss in crop losses and damage to forests. And fourthly, we expect all of this to add up to economic benefits. And according to our calculations, these outweigh the costs largely. The annual gross benefits for 2030 are estimated at 42 billion and even 120 billion, depending on how you evaluate value of life, compared to measures that would cost around 6 billion across the EU each year. But of course, any policy is only as good as its implementation. Earlier this year, we published an update of our biannual environmental implementation review. This pointed to a number of priority actions that would need to be done, including 4 that related to air pollution. Specifically, we call for member states to take further actions toward reducing emissions of air pollutants and to ensure that the full compliance with the current air quality standards is secured. In one specific case, we urge a member state to upgrade and improve the monitoring network, and for several other member states, we point to the need to accelerate the ratification of the EU and ECE conventions in all of its aspects. I've included this slide only as an étoilement to show that there is quite a things that are lined up between now and the year 2030, but I would like to point only to 3 main elements. The first one is the new directive entered into force last December on the 12th. The member states now have until the 11th of December 2026 to transpose this into national law, and by 2030 the revised equality standards will apply, unless of course member states have notified a postponement. There are other important steps in between, but they are for another day and for a longer talk. Allow me to finish with some concluding reflections. First, I started this and I would like to end the talk with it. Air quality policy works. We've seen major improvements in air quality since the 1990s. Our investments into this policy area have paid off and will continue to pay off from a health, social, environmental, and economic perspective. Second, air quality monitoring and air quality modeling provide us with exceptionally robust and comparable and harmonized information across the EU. This sounds trivial, but it puts us in a position where we as a society are super well informed about air pollution in a reliable manner and in real time too. Thirdly, implementation, governance, and communication will be key to harvest the potential for future improvements. This will not come at no cost, but then again, there is a significant funding available also to take these steps. We've estimated that we have funding available in the order of magnitude of 185 billion for the period 2021 to 2027. There's a link to the study at the bottom because of course it's important to have the facts listed up properly. Fourth, yes, some regions face more challenges than others to reach the current and the future standards, but even these regions have seen striking improvements in recent years. And fifth, the Air Quality Directive, when adopted and when implemented as adopted, will render further and significant benefits across the EU. I would like to use just one final slide to alert you to the upcoming 5th EU Clean Air Forum. This brings together several hundred stakeholders and senior level decision makers to discuss air quality challenges and opportunities. It is hosted every 2 years, and this year it will be on the 1st and 2nd of December in Bonn. It's online and on site, and we look forward to you joining. Please do register if you intend to do so. Many thanks.
Thank you very much, Thomas, for your presentation on providing us with the policy framework and making the case again, or confirming that indeed the health benefits of clean air action far outweigh the costs of implementation or of technical air pollution control measures. And thank you also for highlighting the upcoming EU Clean Air Forum. Indeed, where this, it's good to bring to participants here the opportunity for also the health sector and health experts to be part of this Clean Air Forum. I would now like to use the remaining time of our webinar to go and to come back to some of the aspects that were being raised by our speakers, and also taking into account your questions in the Q&A. You can still include questions. Please don't hesitate. It's indeed on the bottom right, the 3 dots, which is the Q&A function. And I would like to start with coming back to the questions of health costs and what is included in costing assessments, as this is something that our several speakers brought up, and start with a question to you, Ludo, on the evidence that you presented on the cost reduction potential of GP visits. And I wanted to see with you if treatment costs were also included in your assessments, and then also since various speakers also touched on socioeconomic health inequalities, is this something you also considered in any of the assessments you did on how far socioeconomic inequalities play a role in air pollution exposure and consequently also in the health impacts? Over to you.
Yes, thank you, Anne, for the question. So to answer the first question, when we looked at the study, we actually only looked at the direct cost associated with the GP and ER visits. This means actually in Belgium, when you go to the GP, for example, it's most often a fixed amount, of which partially you are reimbursed. I think it's like 90%, and then you have a part, about 10%, which comes from out-of-pocket expenditure. Of course, the impact on health is not just, well, economic impact of the air pollution lowering for the health aspect. It's not only about that. So while the 43 million, it's quite a substantial amount, we also know that it would be way bigger if you look at the aspect of reduced costs in, for example, medicines, to reduce costs in working capacity, etc.
Thank you. And obviously further treatment costs. I mean, we're talking, as you had demonstrated, or and as this webinar has demonstrated, we're looking at chronic diseases which require significant treatment costs across the lifetime. Is that something you're considering further investigating?
Yes, we're actually, so we investigated part of it in a study we did with HEAL, which was the one about the low emission zones. In that one, we noticed that we still did not have enough time between the implementation of the low emission zone and the actual impact on the health. But in 2026, we will actually focus on a study about looking at the impact of low emission zones on asthma in children aged 5 to 18.
Thank you. I would like to move on now to Olivier and see with you from what you presented how far socioeconomic inequalities, health inequalities were considered. If it's something you can enlighten us on how the evidence is for France when it comes to air pollution and health impacts of socioeconomic disparities. And then also the question with your impressive methodology, is this something that can be replicated in other EU countries in order to better understand the morbidity rate and also the morbidity costs of air pollution?
Thank you very much for the questions. Regarding the first one, this is indeed something we have explored, these inequalities, through the deprivation index in France, at least, not in the EMAPEC project. And it was an exploratory study because we found some contrasted results because it depends strongly on the structure of the city and how the most deprived population are located within the city and their exposure. In some cities, the most deprived are the most exposed. They are also the most sensitive to chronic disease and so on and so forth. In some other cities, the less deprived are the most exposed. So currently, we do not have a clear pattern, and this is something we are currently exploring to try to determine the association and then the link between the level of deprivation and the health impacts. And regarding the second point, it is true that the EMAPEC project proposed a general methodology for conducting HIA involving short and long-term morbidity. I only present today long-term morbidity, but the report is going to provide concentration response function for short-term impacts, for long-term impacts of morbidity, based on the review of the literature, systematic review, meta-analysis, and then this concentration response function can be used in every country, provided that the data on pollution, on population and health are also available, and then it is possible to make estimates for a given country. Regarding the economic data, they will need to be adapted to the country's health system and the standard of living in order to be consistent with the approach. Thank you.
Thank you very much for highlighting this, and I hope this is an inspiration for those of you who are listening, as indeed this will be an important tool in the implementation of the Ambient Air Quality Directive, as we heard that this is currently going on. Olga, when coming to you next, I don't think we need to hear from you on the case on socioeconomic inequalities. I think from your presentation that became very clear on how Poland is especially affected, and on the inequalities between also EU member states. I wanted to ask you about the involvement and the engagement of the health sector, since you ended with this from your experience and your work. What do you see in terms of increased awareness of the Polish health sector, and in how far does a highlighting of the costs, the health costs linked to air pollution, how does this help in the health sector being engaged on clean air?
Yes, so maybe I will divide this question to two parts. I will briefly talk about the group of doctors that we work with and that we know that are engaged with, but I want to also talk a little bit about more of a system level and what gaps there still are regarding health engagement. So as I briefly mentioned, we do collaborate with a group of, I think, around 70 doctors right now, both on air pollution and on climate change. Some of them are really engaged when it comes to environmental health and making a change when it comes to policy. We also collaborate, for example, with National Medical Chamber, and we are doing training for doctors to try to at least a little bit fill in the gaps when it comes to knowledge of medical practitioners. So when it comes to the level of like more of a health system, there still are a significant gaps, and I do believe that there's still not enough emphasis on environmental health and the connection of environment and health, and it goes deeper to the fact that doctors a lot of times do not know how to connect the fact that the patient comes for example, during a day with a high air pollution and how that impacts, their health. So I believe that there are a couple of problems. First, I do believe that it would be beneficial to integrate environmental health topics both in Public Health Act, but also in the strategies that we have, the long-term strategies. It is also important that the Ministry of Health, right, collaborates with other ministries, because air pollution is not it's not only an issue of the Ministry of Environment, it impacts health, it impacts economy, it impacts a lot of things. So this intersectional actions are needed. And then also to integrate environmental health into medical curriculum, because for now, again, we have doctors that are really aware of the topic, and there are doctors that struggle to actually apply this knowledge to their work and to see multidimensionally. But yeah, I do believe that it would be beneficial if both in pregraduate training and also postgraduate it would be implemented.
Thank you very much. Moving on to Thomas for the last question. As I said in the beginning, this webinar aims to raise awareness on the health impacts of air pollution and the health costs. And of course, awareness starts with having the information on air quality. You mentioned that there's an extensive monitoring system in place. So yeah, where do I go as a concerned parent or as a patient? How can I inform myself? And then you also mentioned that there will be some changes on air quality indices with the new ambient air quality directive. Could you say something about that? Thank you.
Thank you. Yes. Well, I mean, let me start off by saying that all the data that is monitored and reported to the Commission is made available to the public via the European Environment Agency. There's an air quality portal, so anyone can go in and look at the details in real time, the statistics, the annual statistics. The EA also produces an excellent report called the Air Quality in Europe report, which provides a synthetic overview. And there's also city rankings, et cetera, et cetera. So all of this information is available easily via the European Environment Agency, and most member states also have their own bespoke platforms in which they make this information more and more available. I mean, this is a huge difference today compared to 10 years ago. But maybe the most convenient way to do so, to look at data for people that are not aiming to become air quality experts and dive into the detail, might be to look at the European Air Quality Index or at indices developed at local level. And what they do is they actually look at the air quality that is reported and present this in a color coding, and sometimes even these are picked up by weather forecasts or other apps. But this European Air Quality Index is available both online and as an app. It allows to look at the data in real time, both for the monitoring stations and for hourly data. And actually, I can show you quickly what, no, I can't show you what it looks like. Actually, I can by gaming the system. So you would have on your mobile app a map like this. This is the situation in air quality pretty much right now. This is a modeled map. With a click of the button, you would also see what the monitoring stations say, and you can zoom into the one that's closest to you. So all of this, of course, has to be taken with a grain of salt. All of this is always the hourly information, but we as citizens actually now have access to information about poor air quality when it happens pretty much at our fingertips. And I encourage you all to use it. Thank you.
Thank you very much with this very hands-on finishing of our webinar. And with that, I would like to thank very much all our speakers. The conclusive remarks, I can keep them very short. I hope that you found this webinar useful on understanding and hearing some of the evidence on how poor air quality impacts health and the significant costs so linked to it. So also the significant prevention opportunities. We learned about one policy framework in this webinar. There are, of course, many other current EU policy deliberations where this information and this inserting the health evidence will be useful. Also, your engagement as participants, including the upcoming the upcoming EU beating cardiovascular disease plan, the further implementation of the beating cancer plan. There's an EU urban agenda being updated, and last but not least, we are in the middle of the negotiations and deliberations on the next EU budget, where it's important to actually have adequate financing allocated for further clean air efforts. And with that, I would like to close this webinar. Thank very much our speakers. Thank you very much as participants. Thank you to the EU Health Policy Platform. The recording will be available on the Health Policy Platform website, but also on HEAL's YouTube channel. And this was the first in HEAL webinar series, so please have a look at HEAL's website for any upcoming webinars. Thank you very much again, and back to you, Clementine.